Hello, welcome to the Colorado Dental Assisting School Week 1. We are going to discuss general introduction to dental terminology. We have a lot to review in the next 10 weeks, so this lecture is going to give you a preview of all of that and get your mind, rolling and get that memory started on all the different subjects that we are going to cover in this course. The first one we always want to talk about is professionalism in dentistry, so that is where we will begin. All right, so we want to make sure you guys understand how big this is for dentistry. We need our dental assistants and all of the dental staff to remain professional while in the office and also while outside of the office. It's a very big deal when you guys are wearing scrubs and you go to lunch and, we start talking about our day and what was going on, and that's completely normal. But we want to be very careful on what we say when we're out in the public eye. We always want to remain professional, whether it's in the public eye and we're out to lunch or it's on social media. So keep in mind, the dental professional world is very close-knit in Colorado, and when you post something on social media and it also shows where you work, that's going to directly reflect on them. So just try to keep in mind that because it can become an issue if we aren't keeping that professional attitude and making sure that we're treating all of our patients with respect and we're not sharing any information outside of the office on a need-to-know basis, which we will discuss when we talk about HIPAA as well, so that way we can keep our patients safe. In order to gain a patient's trust and respect, we need to first address why they're there with us, and we also need to show them that, we're not in a rush and we're here to take care of them. They are our #1 priority. Whether we're running behind on the schedule or maybe they came in late and they were actually the ones that caused us to run behind, things happen. Try to give them the benefit of the doubt that it might have been hard for them to come in there and see us that day. So this slide is just talking about personal and professional attitude, patient fears. A lot of patients are afraid of the dentist. You're going to hear that when they come in. They're going to tell you, I hate the dentist. It's usually something that comes out of their mouth, and they don't mean it in a nefarious way or trying to be rude, but it does happen, and you just got to brush it off and give them that amazing smile and make them feel welcomed and that they are in a safe space where they can share these feelings, and we're not going to rush them. We're going to make sure that this is a two-way street and a good relationship that we have with the patient as well as the patient has with our staff. So try to give them, reasons why this is going to be a better experience for them. Reassure them that, if I don't have the answer for you, I will definitely call the doctor in here and we will find an answer for, whatever your concerns may be. You always want to ask them about themselves. So that's a great way to get to know your patients. They're there to build that relationship with you. So the last thing you want to do is be like, oh, I was running late this morning too, right? Yeah, let's not talk about the elephant in the room. Even if they were running late, not okay, not professional. So, try to ask them, hey, the holidays are coming up. Do you have plans? Are you going out of town? Or are you ready for this snowstorm that's scheduled? Or, what, it's really nice out. Have you, been able to get to any of the summer things that have been going on in the city? Try to talk about things like that are more uplifting. We don't want to cause any more anxiety that they might already have. So definitely ask some questions about themselves. If they seem more reserved and they don't want to talk, maybe just let them take it all in. Ask them if they want, can I get you a glass of water, or would you like to sit in, in the dental chair? Would that be more comfortable for you? Previously I've had a patient come in and specifically just sit on the bench in the room, not even sit in the dental chair ready to be examined. And she had high anxiety. And so, I wasn't like, well, you need to sit over here. We got to get this going. Come on, let's go. What are you doing? You just need to be able to take it all in with them and slow down for a minute. Let's all remember why we're here and what we want to accomplish, which is giving them the best possible experience in our office and with us that we possibly can. So to do that, sometimes you got to put yourselves in their shoes and maybe just back off and give them a little bit of space. But it's good for you to take that road and try to assess the situation and see what it is that patient needs from you. Appearance is huge in the healthcare system. We don't ever want to come to work and look like we aren't ready, right? We want to come to work prepared, have our scrubs on, make sure they're clean, make sure we have a lab coat on. Before we see that patient, we should have everything in the room that we need, right? We don't want to be running in and out of the room unprepared. Cleanliness should never be subject to question by the patient. That is a very good point. Your patient should never say, hey, are you not feeling well today? Or are you sick, right? If you're sick, by all means, please stay home. Don't get the rest of the staff sick, right? Your team members are not going to be happy. And even if you are wearing a mask most of the day and you're sniffling the whole time, remember this patient has their mouth open in front of you, and that's not very attractive. So let's try to, put our best foot forward, make sure our hair is short or pulled back, that it's not in the patient's face when we're bending over them. You don't want any watches or rings with sharp edges that could cut one of your gloves, so we want to think safety. We want to stay away from long or acrylic nails because they can get caught in some of our instruments and the materials that we use for dentistry, so that could also be a safety issue as well as cleanliness. There is, under no circumstances, is it okay for you to eat or drink in the treatment room. Now, the patient can have a beverage in the room, that's okay, but for us as healthcare professionals and dental care providers, we are not allowed to be eating or drinking in the patient rooms, in sterilization, really anywhere but the break room. So keep that in mind. That is an OSHA violation if they see you with your coffee or your water bottle or, your energy drink or whatever the case may be. Don't bring it into the treatment room. Even if you're just clocking in real quick, just try to make good habits. You don't want to start creating those bad habits and then pretty soon you get really relaxed on it and other things start to become issues. So again, remember, you need to wear closed-toed shoes at all times when you are working in this office. You cannot have any shoes that have exposure to your feet. So even if they're tennis shoes or some of the Danskos or the Borns, that's okay too. As long as they are closed-toed shoes and your foot is completely covered, you are within OSHA regulations. Teamwork. This is such a big deal in dentistry. We all have different tasks and duties and all these responsibilities that we need to get done before the patient leaves, right? And before we go home at the end of the day. It's important that before you leave, you ask your team members if they need help, right? Go to your hygiene team. Hey guys, how's it going? Do you need help? I'm about to head out. Just wanted to check with you guys real quick. They will appreciate that. And you guys will run like a well-oiled machine. And when review time comes, right, you are going to look like that hardworking employee that you are. Instead of trying to prove yourself, it's easy for them to see, hey, so-and-so stays late, or it's not even really about staying late, but they're a team player, right? They check with everyone before they leave to make sure that everyone is where they need to be and that they're getting the help that they need. When you're new, you're going to expect that from them, right? When you guys get hired and you're fresh out of school and you feel like you don't know anything because you still have so much to learn and so much experience to gain, and that's great. But you are going to expect them to take a moment out of their day and to show you how to do things, right? Everyone has to start somewhere, but try to, give that back to them and let them know, hey, I am here. I show up every day on time. I have a good attitude. I am able to ask questions and help at the front office, answer phones, greet the patients when they walk in. It's not, oh, that's not my job. You never want to have that type of mentality or you will not move ahead in this industry. So, show that appreciation for your coworkers and offer that helping hand and help out. Staying for the full shift is a big deal. We're talking about patients in this industry, right? It's not like, oh, you were scheduled from 12 to 3, you can leave at 3 o'clock. No, I'm sorry, but if this patient, if their treatment runs past 3, you will be expected to stay. And pretty soon you'll know how fast your doctor is able to do these different types of treatment plans. So you'll be able to look at the schedule ahead of time and go, oh, you know, since this one's scheduled at the end of the day, we're probably going to take another 15 to 20 minutes to clean up after because it's a root canal and there's a lot of little pieces that go along with it, you know? So try to plan accordingly if you need childcare or if if you pick someone else up at the end of the day and you're not able to carpool with them, whatever the case may be, try to stay for your full shift at all times because these patients are counting on us to be there for them. And not only that, but so is our team, right? So we definitely want to make sure that we are staying for the full shift and arriving on time. Confidentiality is a very big deal in the healthcare world. We are going to talk in more detail about HIPAA, but what I want you to take away from this slide and from anything that you hear in the dental office is that whatever is said in the dental office must remain confidential and you don't discuss it outside of the office. And not only that, but you don't discuss it with another doctor or another coworker in the office. So the HIPAA is Health Insurance Portability and Accountability Act. And one of the biggest confidentiality rules is that we don't share any information about a patient unless it's on a need-to-know basis. So let's say you're working for a general dentist, and in that office, you have 2 general dentists and a specialist. Let's say it's an oral surgeon. And let's say the oral surgeon comes up and says, hey, you know, I walked by and heard you guys talking about possible extractions or something. Or, you know, maybe they ask a question about the patient. You are under no circumstances allowed to share any of that health information with that provider or with anyone else in the office, whether they be an employee or not, because it is on a need-to-know basis. Now, if we were referring that patient over to the oral surgeon or possibly that other dentist, then absolutely give them the information. We scheduled them with your team. Here's the day they're coming in. Here's the x-rays we took. Here's the chart notes. This is the treatment plan moving forward. That is a need-to-know basis, right? That doctor needs to know what the treatment is, how they've been diagnosed, what the exam shows for the day, and why they were referred over to them. Then absolutely, you need to share that health information. But if this is just a personal inquiry or any sort of inquiry that does not need to know about that patient, you are not allowed to share that information, whether you work together or not. It is not okay to share another patient's information with someone who isn't going to be their provider. Let's talk about employment settings. So there's so many different options that you guys can do with this dental assisting certificate. So it's really exciting. You could work for a solo practice. So that usually means 1 dentist, a couple hygienists, and a couple dental assistants, usually 1 front office person, maybe 2, depending on how busy they are. And they usually only have 1 location. We are moving now more towards group dentistry, and the group practices are able to hire more specialty under them and also have several offices with general dentistry as well. The great thing about a group practice is if your doctor goes on vacation, you don't have to go on vacation as well, which is the majority of the time because guess what? We don't work without our doctors. So in a group practice, the nice thing is if they go on vacation, you can try to pick up hours at another office. Maybe they have someone else out or someone called in sick, or maybe they just need help making phone calls, trying to fill that schedule. So again, you know, make sure you're being trained on the front office, how to check out a patient, how to accept payment, how to run insurance inquiries, all those different types of skills, and not just limit yourself to dental assisting, because those skills will come in handy when your doctor's out of town and you need hours, right? You're not just like, oh yeah, okay, I'll take another 2 weeks off, no pay. I mean, unless you can do that, then that's great. Specialty practice is always fun. We've had a lot of dental assistants graduate from our program and go into specialty. A lot of them into ortho. They seem to really love ortho. So if you're interested in ortho, perio, oral surgery, or endodontics, let us know. And we are more than happy to try to get you involved with that boot camp and internship. It's great. So you are more than welcome to apply for a specialty practice position as a dental assistant after you graduate, or even before. We've had people get hired before they graduate as well. Public health dentistry is a really big thing here in Colorado. Downtown at Peak Vista, they have hired many of our graduates, and they do actually have you take the Dental Assisting National Board as part of their review process to hire. So just so you know, our students have done really well. They've passed with everything that they needed to study from our class. So that is an option at that office. There's a couple other ones out there that are traveling, and there are some charity ones as well that you can look up. I don't have the information on me right now. I can't think of it. But if you're interested, email me, and I'm more than happy to give you the information if you ever want to donate time once you get some more experience under your belt and help with that public health dentistry. It's a really cool thing to do for the community. Insurance, if you decide, you know what, I can't work in anyone's mouth, I can't handle it, this isn't for me, which you're not going to know until you do it, and that's okay. You can work for a dental insurance company. You could also be an instructor. We would love to have more instructors. However, you do need at least 2 years of dental assisting experience. More is usually preferred for the Board of Education to approve you. However, that is something that you could always go into. And then the really fun one is dental product sales representatives. We absolutely love them. So I'm talking about like Colgate, Crest, Aquafresh, you know, any of those dental product sales representatives that go around and sell all of the products that we purchase on a monthly basis to run our practices. They come in and they buy us lunch, and they try to sell us new bleaching techniques, and it's fun. It's a great time. They're really awesome people, and we absolutely love them. So that's always an option as well, if that's something you're interested in. You could work front office if you have a management background and that's something you're interested in. You could always go front office too. The roles of a dental assistant. Some of you might be a little confused about it if you have not used Google to look up what you'll be doing as a dental assistant. So let's discuss that. So you'll be working directly with the dentist in treatment area, practicing four-handed dentistry. So your primary job will be to seat and prepare for the patient. You'll be charting, which a lot of them are electronic charts now on a database that is on the computer. We don't do too much paper charting anymore. However, you are going to learn how to paper chart in this class because we think it's important for you to understand that. You will be instituting infection control, which we will discuss when we talk about OSHA and safety and our spray wipe spray method of disinfection. You'll be mixing and passing dental materials, ensuring patient comfort. So remember to check in with your patient, ask them questions. The first question out of your mouth when you see them should be, have you had any changes in your health history? Even if you saw them the day before, the night before, you don't know what happened overnight. So you always want to ask them, have you had any changes in your health history, any new medications, hospitalization, anything that's changed that we need to update? X-rays will be a big part of what we do as a dental assistant. We take X-rays every day. Impression taking, model pouring and trimming, and laboratory responsibilities. Patient education is a big part of our job. Post-operative instructions. They need to know exactly how to take care of themselves before they leave. And you could be somebody who also does inventory and ordering for the office. So all of those dental products that we were just talking about that they sell, you'll be in charge of making sure that that inventory is up to date and we're not running out of a product that we need to help our patient. OSHA compliance is a big deal as well. We want to make sure that our office is running efficiently and in compliance. So not only are we ourselves safe, but our patients are safe, right? That's a big deal. Sterilization is, of course, part of our job, right? We got to clean up after ourselves. We're going to make a lot of dirty instruments, so we do have to sterilize those instruments, and we are going to show you in the lab today how to go into the sterilization area, how to wrap the cassettes, how to put the cassettes together, how to bag instruments, and to keep yourself safe, which side is dirty, and also which side is clean. You'll be responsible as well for placing dental sealants, which you will learn in week 7. Impression taking, temporary crown fabrication, packing cord. That might come maybe 8 to 9 months down the road once you've been a dental assistant for a little bit longer. Applying fluoride, applying topical anesthetic. We do not give injections. So if any of you were worried about that, only a provider is allowed to give an injection in the state of Colorado, and we are not considered providers. We work under the dentist license, so we are not considered a healthcare provider. We are their assistant, so that therefore we'll be giving topical anesthetic, and we will show you how to place that on week 6 and where it goes, and a good way to do it so your whole mouth isn't numb and you're not salivating everywhere and swallowing it. That's never fun. But we do not give injections, just to be very clear. And placing and removing dental dams. Yay! We'll be doing that in week 2, not on each other. You do have to be numb to have that done. So we will be placing and removing dental dams on a typodont. And then expanded duties dental assistant would be the next step. So once you've been a dental assistant for anywhere from 6 to 9 months, sometimes even a year, a lot of times our dental assistants will want to go to a continuing education class, which is our expanded duty dental assistant. They will be placing and removing matrices and wedges, applying liners, bases, and varnishes, placing, carving, and finishing amalgam and composite restorations, and removing sutures. So these are all permanent things that can be done in the mouth. Only an expanded duty dental assistant or a dentist is allowed to be placing fillings like this and carving and finishing them. It's so much fun. I absolutely loved it when I did it, and I hope that you guys will grow in this industry and become an expanded duty dental assistant as well. It's a lot of fun, and it's a chance for you to really be creative and be in the driver's seat, right? So you're not always the assistant. You actually do get to place fillings on your own and apply liners and all that good stuff. The doctor is always responsible to check all of that before the patient leaves. So I don't want you to feel like, oh my gosh, this is really intimidating, because it is. It can be. But that's why, they wait until you're ready. So that's always fun. All right, let's talk about phrases to avoid saying in the dental field. An appropriate word would be discomfort. Inappropriate is pain. Obviously, we know they're in pain, but we, again, want to create this safe environment for them where they feel comfortable, right? Where they can talk to us. And they're going to tell you, I'm in pain. This hurts, right? I am so sorry you're feeling this kind of discomfort. We're going to take care of you today. That sort of talk is a lot better than, this is going to cause a lot of pain, right? And they're going, okay, why am I doing it? We know it's going to cause pain, but we don't want to scare the patient. We don't want their blood pressure to rise. By all means, we want to be very, very upfront and honest with them, because we want them to understand how long it might take for them to heal if they're having oral surgery and what to expect. But again, we don't want to cause any sort of anxiety for the patient. So it's all about our words, right? Linguistics. It's going to be important. So try to keep this in mind. When you're answering the phone, or let's say you're making phone calls, you want to let the patient know we have a change in our schedule. Can you come in earlier? Don't tell them that we've had a bunch of cancellations, right? Because then they might be thinking, what? Maybe I should cancel, right? What's going on over there? And who knows why people cancel? It could be a change in their personal schedule or work schedule. We really don't know. So always try to keep that professional approach and let them know, hey, we had a change in our schedule and we want to know if you could come in earlier, or we're going to have to reschedule you. Prepare. We prepare the tooth for a filling. We prepare the tooth for a crown. We don't drill. Please do not use the word drill. It is absolutely terrifying. I'm sure you wouldn't want anyone to use it when they were talking to you. So try to stay away from the word drill. Treatment room, operatory. A lot of times patients, when they hear operatory, they think surgery, and it kind of freaks them out. So try, if you can, at all times to use the word treatment room as opposed to operatory. Reception area as opposed to waiting room is always a really good one. We know that they're waiting, and we want to let them know, hey, can you have a seat in the reception area, and we'll be with you shortly. Keep checking up on your patients if you're running behind. Please keep them up to date and let them know, because they might have to go back to work, or go get their little ones, or go do whatever it is that they need to do. They have lives outside of us, right? So try to keep that in mind. Do not make them wait on you. And if they are waiting, give them a time period, because they might be like, you know what, in 10 minutes, I really got to get going, or I can't get back to where I need to be in reasonable amount of time. So let them know. Dental treatment as opposed to dental work, we are going to give them a treatment plan that lets them know what they may or may not need to have done to make sure that their mouth stays healthy. So dental treatment is always a good way to say that. Fees, price, there's really not a way to sugarcoat it, right? This isn't free. We're not giving away the farm here, people. But there will be a dental fee. Fee is always a good one to use because that's the way the insurance will describe it. This is an insurance fee. Always remember that this is usually an estimate and that they can, call the insurance to make sure that there won't be any extra fees outside of what the estimate is that we're giving them that day. Injection. I try to stay away from these words at all times. They know they're getting an injection. They know they're getting a shot. So what I try to let them know is, have you ever had any, I ask them, have you ever had any adverse reactions to having your mouth numb or having an injection? If you have to say the word injection, it's okay. Try not to say the word shot. And a lot of times I will place the dental bib over all of our instruments and especially over the syringe because it freaks people out. That's usually their biggest issue with coming to the dentist, and what makes them so nervous is seeing the needle and knowing that they have to get a shot in their mouth. So in general dentistry, that's what we do. We restore the mouth. So it's going to be very common that when patients are coming in, we're doing treatment with them. We're not cleaning their teeth like hygiene. They're going to be getting an injection. And sometimes we can do it without it, but you definitely want to ask that question when you're talking about health history with them, if they've ever had any adverse reactions to being numb. Examination as opposed to checkup. They are going to get an examination when they come in to see the dentist. It's important that we let them know what is going on. Because that way when they leave, they're not like, oh, I don't even remember, did I get an exam? Let them know, remind them what they're there for. We have former patients. We don't have old patients, okay? Try not to say old patient. We have former patients. Extract, we will extract your tooth. We extract teeth. We don't pull teeth. The doctor's with a patient or he or she is busy. It is so important for you to keep up with these patients if you guys are running behind on your schedule. And it happens. It doesn't happen all the time, hopefully. Hopefully we can, run a tight schedule and we're okay. But it will happen. Don't be afraid to go in there and let them know, hey, you're next. Or you know what, there's 2 more people ahead of you. This is what we're looking at. We had an emergency come in. Be very clear with them. Do not keep them in the dark. They don't like it when you ignore them. So be upfront with your patients and make sure that you follow up with them when they're in the dental chair. All right, dental anatomy and terminology. So what you see here is our lower jaw, which is called a mandible, otherwise known as a mandibular jaw. You have your top arrows up here pointing to your condyles, which seat right into your temporal mandibular joint. And it just pops right into here. You have your mandibular foramen, the ramus, and the mental foramen. In week 6, we will talk about how the nerves come into the jaw and exit, and we'll also show you where exactly to place your topical anesthetic. So that way when the doctor goes in to give the injection and numb the patient, it's good and numb on the outside and it's not as big of a pinch. I'm not saying they won't feel it at all, because we all know if you've ever been there that it's not fun, but it usually does take away that first initial pinch, which is usually the worst part. Dental equipment. So what you see here on the left is an autoclave. You will be using one of these in the office to sterilize instruments. This one here is a panoramic machine that we can use to go all the way around the head, and it shows both upper and lower jaws. We have a picture of someone in sterilization packaging instruments ready to go into the autoclave and be sterilized. It's important that you note that she is wearing her mask, eyewear, which is kind of hard to see because they're clear, her gloves and lab coat, and of course scrubs and closed-toed shoes. We also have a picture of our x-ray head in here taking x-rays. You guys will learn how to take a full mouth series of x-rays in this class, and you will be radiology certified. This dental assistant has her lab coat and gloves on, which is all you need for x-rays. And of course, the patient has their lead vest, including a thyroid collar. And we have our coverage and RIN in the patient's mouth with the x-ray sensor. It's really important that we have everything put together when we're taking x-rays. And you guys will learn more about how to put the RIN together on week 3 and 4. Four-handed dentistry. We will work side by side with the dentist to restore the patient's mouth, whether we're doing fillings, denture, extractions, root canals, whatever the case may be. So this is what they call four-handed dentistry. So you'll see here in a close-up picture how we will be passing instruments to the dentist. So in your pinky, you're going to grasp the one that they've been using. You'll end up tucking it under, and then you will place the one that is in the thumb and forefinger into the dentist's hand with your left hand. You'll notice that the assistant has the suction in her right hand, and she's got her thumb right on the open and close, so she can open and close that, or she can turn it on and off easily. So if you suck up a patient's cheek or tongue, you can either rotate it off or turn it off. That way we don't end up giving them a hickey, a hematoma on their lip. That wouldn't be fun. Your initial reaction is probably going to be to pull back. I'm not going to lie to you, because when it first happens, it's kind of a little scary and it's loud. They're not going to get hurt though. Just go ahead and turn it off and try not to yank on it, because you might have that reaction at first. In her left hand, you'll notice she is holding the 3-way, otherwise known as our air water syringe, and the tip in the patient's mouth. So it looks like she's holding her tongue back with the airway and then suctioning with her HVE, which is your high volume evacuation. The dentist has a mouth mirror in his left hand, which he is pulling her cheek back with, and his handpiece in his right. And notice they're both wearing eyewear and masks and lab coats with their gloves as well. It's really important that we have all of our personal protective equipment on whenever we are working in the mouth. Radiology. So again, we are going to review this on week 3 and 4. We have dedicated 2 weeks out of this accelerated 10-week program to radiology. However, you will be taking x-rays through the whole course. So don't feel like, oh my gosh, I got to get it in those 2 weeks. You will be doing it throughout the entire course. And on week 9 is your radiology exam. You will need to bring in a patient for that exam. They cannot work in the dental field. So make sure you understand that now. Let's be very clear about it. It is on the student portal. There is an important document that talks about exam requirements. So if you want to go on there and check it out, it'll remind you what the qualifications are to take your radiology exam. So in this picture on the left, you'll see that patient is having a panorama x-ray taken, and she does have a lead vest on that covers both her front and back. In the middle picture, you see the panoramic x-ray, which is really amazing. So you can see all the way to the condyles, the ramus, and all the maxillary and mandibular jaws, the teeth, and part of the sinus. On the right side, you can see the dental assistant is taking an x-ray of her maxillary incisors. On week 5, we will be talking about restorative dentistry, which is a lot of our fillings. So we do still use amalgam and composite fillings. Amalgam is one of the strongest materials that we have for fillings, but composite is starting to get better and get up there. So it is aesthetically pleasing. It's definitely the more popular option because a lot of people don't want that metal look in their mouth. You will learn how to place these. You'll learn the sequencing of the restoration, all the instruments needed, and materials in the order that they go. In week 5, we'll also be discussing impressions and model pouring. You guys will be taking alginate impressions just like this picture here. You'll be pouring up a model and making your own bleach trace. In week 8, we will be talking about specialty, which does discuss oral surgery. In week 7, we'll be talking about crown and bridge. So that is not part of the specialty, but it is definitely the bread and butter of dentistry. This is something that we do often to restore teeth. That way we don't have to extract them or root canal them. So what you see here is the sequencing of a crown being placed in the top picture. In the middle picture, you see a 3-unit bridge. And in the lower picture, you see 2 anterior crowns. Another specialty that we'll be reviewing is endodontics. So you will learn all of the materials and instruments needed to place a root canal, why we need a root canal treatment, and the different types of surgeries that endodontists do. We'll also be discussing orthodontics. It's one of the more popular specialties that our students like to go into. We will discuss pediatric dentistry as well. A lot of our students have actually gone into pediatric dentistry. So it is just like general dentistry, it's just for kids. So you probably won't be doing as many crowns, or we hope not, right? We hope they don't need that kind of work done when they're little. But they will be doing everything that we do in a general dentist office. Most general dentist offices see all ages though. So I don't want you to feel like, well, I don't want to deal with kids, so I'm going to go into general dentistry. Well, I'm sorry, but they still see kids too. So just so you know, if you're trying to stay away from the little ones, there's really not a specialty that doesn't see them often. Maybe oral surgery, they don't get as many children unless you're working in a hospital, someone's in a car accident or something like that. But in general dentistry, we do see all age groups. We are going to discuss the front office, how important it is that we support them and that we learn how to check patients in and out and take payments, and also what type of insurance your company accepts, which is usually a really common question that we get when we answer the phone. All right, let's talk a little more about dental terminology and dental anatomy. The tooth life cycle. We're going to talk about 4 different processes of formation. We're going to talk about odontogenesis, the growth, calcification, and eruption. If any of you have children, or if you remember when you were little, we all go through teething, right? That's what we call it, teething. So before we're born, there is a bud, which is the initiation, which begins the formation of dental lamina, which is a thickening band of oral epithelium that follows the curve of each developing dental arch. It produces 10 enlargements in each arch of primary teeth. So as children, we should have 20 teeth. We should have 10 teeth on each arch. Once this process is done and it starts to continue, the cap will develop. And it kind of looks like a little tiny crown is inside of a circle when you see it in an x-ray. And that will start to bud and change and grow. Once the bell starts to produce, it's going to, the cells continue to differentiate in a process called histodifferentiation. So the enamel starts to form, the odontoblasts start forming dentin layers, and then the cementoblasts start forming cementum layers. In a couple more slides, you'll see a picture of a blown up tooth, and you'll see the anatomy. And we will teach you the anatomy of the tooth in each layer of it, all the way to the dental pulp, which is where your nerve, artery, and vein are. So this will continue to develop the roots and the cemento-enamel junction. Eruption. So this is the movement of the tooth into its functional position in the oral cavity. Don't you wish it was that easy though? How many of us have had ortho? It's like, yeah, that one didn't go into the functional position. That's okay though. That's where it's headed. Sometimes our hereditary genes kind of make a different road for us. So vertical movement of the teeth is considered eruption. A lot of times in babies, you'll see they start to swell a little bit, or the gums will start to blanch and turn white right before the tooth breaks through. The other process is called exfoliation. So this is a normal process by which the primary teeth are lost as the permanent teeth develop. So what happens is your permanent tooth starts to come in and develop that little bud and cap. And as it's developing, it's sending a signal for the cementoblasts to start reabsorbing that root back into the body. So here is an eruption sequence of teeth. So it's telling you 5 months in utero, so 5 months in your mother's belly. You already have some little buds in there. 7 months in utero, you have all of them budding and getting ready. At birth, you have all 20 teeth underneath your gingiva. At 6 months, normally around 6 months, we start to erupt our central incisors, which are our front lower teeth. And, you know, some kids don't even get them until they're 1. So it's kind of hard to say because everyone's a little different. Everyone is on their own timeline. So if your child, or maybe you didn't get them until later, it could just be hereditary. But this is telling you eruption sequencing of teeth. So you'll see around 5 to 7 years, we call them your 6-year molars, which are these adult molars here. They're also called your first molar. This one will erupt first, right behind the baby dentition, and your premolars will replace your baby molars. And then your canine will follow suit, and then your lateral and central. And then hopefully by 21 years, you will have all 32 teeth. Some people do develop wisdom teeth. Some only get 1, some get none, some get all 4, some even get an extra, which is called a supernumerary. It's not 33. If there's anything extra other than 32 teeth in the mouth, it's called a supernumerary. Sometimes they will develop in the sinus area and come in through the roof of the mouth. We've seen some pretty interesting things happen, and a lot of times it's hereditary. So this is that blown up picture I was telling you about. So when we were talking about the cementum, blast, and dentin, this is what it looks like. So you have your apex of the tooth, which is right here, which is the tip of the root of the tooth. So this is a multi-rooted tooth. So we have 2 apex. On this incisor, actually it looks like a canine, we have 1 apex here. The bone is your alveolar ridge, which is your jawbone that surrounds your teeth. Your cemento-enamel junction is right where the enamel meets your dentin layer. The crown of the tooth will be the area that is also referred to as your anatomical crown that you can see here. The dentin is this yellow area. So the majority of your tooth is made up of dentin. It's a lot more porous and it is not as strong as the enamel. The enamel is the lighter colored area of the tooth that's on the outside, which is the part that we love to chew our food with and smile and bleach, all that good stuff. That's your enamel. Your sulcus is right here, this space between your gingiva and your tooth. So think of it like a little moat around a castle. That's your sulcus, and it goes all the way around your tooth. That's the area that we floss really well, right? We scrape the side of the tooth to get all of those pieces of food and bacteria, everything else that's in there out, so it does not turn into calculus. Your gingival margin is going to be right where your gingiva ends. So if you have recession, your gingival margin could be down here. Hopefully not, but that could be the case. Your pulp canal is going to be right here where you see your nerve, artery, and vein come through the tooth. So this one has 2 pulp canals, and it could have more than that. We would need a microscope and to open the tooth up to look. And then, of course, you have your pulp chamber, which is these little pulp horns. And this is where the nerve and artery and vein reside inside of the tooth and keep it alive and feed it nutrients and all that good stuff. So when we say, you know, diet affects your teeth, and having a healthy diet and healthy exercise and all that good stuff, that will affect how healthy your teeth are. Your periodontal membrane, or otherwise known as your periodontal ligament, is this sorry, not the green guy, right in between. So we have a blown up picture here. So right between the bone and the cementum, we have dentin, cementum, periodontal ligament, and bone. This guy goes all the way around the root. And that will tell you, ouch, you're biting too hard, right? Back off. That doesn't feel good. If your periodontal ligament gets swollen, a lot of times when you have a tooth that needs a root canal, you feel like you hit it constantly. Like, gosh, I keep hitting that one tooth and it really hurts. Probably because the periodontal ligament is swollen. The root is the surface of the tooth that is inside of the bone area. So this area here, right next to the CEJ, which is your cemento-enamel junction, is all of your root surface underneath there. This goes into a little more detail of the tooth anatomy. So the enamel is the hardest material in the body, so it's going to protect and cover that softer layer of dentin underneath. So it's good for crushing, grinding, and chewing. It comes in all different shades. Some people have more of a yellow color. Some people have more of a gray or like a grayish tint. It just depends. The dentin is the main portion of your tooth structure. And it is a little light yellow in color, which you'll be able to see. Inside your dentin, you have fibers and tubules. And the tubules are kind of like little pores in your skin, in your dentin layer. And that is the area that's most sensitive. So if you do have any sort of gingival recession and you eat something or you drink something cold or hot and you're like, oh man, that tooth hurts every time, it might be because some of the dentin is exposed and it's not as strong as the enamel. Again, the pulp chamber is where your nerve, artery, and vein reside in your tooth. And your root is embedded in the alveolar bone covered with cementum. You could have bi- or trifurcation divisions of roots, depending on the tooth. And then, of course, your periodontal ligament. Every tooth has a periodontal ligament. So that's the connective tissue organized into fiber groups that connects the cementum covering the root of the tooth with the alveolar bone of the socket wall. This is a profile picture of the entire skull. So you can see where that condyle seats inside of the temporomandibular joint, right next to your ear. So if you ever hear people say, oh, I have TMJ issues and I always get headaches, or it hurts my ear and I get earaches, it's all connected right there next to the main muscle that covers your skull. So it could easily create problems with the ear or headaches or migraines. So you want to make sure that you don't have these kind of issues. So this blown up picture shows you the condyle right next to that temporomandibular joint ligament. If this isn't seating correctly, you'll have popping and pain, and you'll kind of do a little right-left jiggle when you open your jaw all the way, and it will try to make up for it. If you bite your cheeks often, it's probably because this is not seating correctly. The main reason for that not seating correctly is because your teeth are not in a proper functional occlusion, which means your bite is off. So to fix that, a lot of times the dentist will refer you to an orthodontist or possibly an oral surgeon if you're a more advanced case and your jaw has finished forming. Certain cases do need oral surgeons. In this picture, you see the mandibular jaw again. And this mental foramen exits right here, right after the canine and right in front of the second premolar. So this nerve that it's pointing to in red is your inferior alveolar nerve. And a lot of times when we give that injection in the back of the mouth with the long needle, we will do that to block that half of the jaw. It will also numb half of the tongue and all the way out to the lip. So we usually ask our patients, is your lip numb? And then we know for sure it's okay to start working on the patient because they're completely numb. If we were to give an injection right where the mental foramen is on the buccal side, which is the cheek side here, then it would only numb to the midline of the body, which is right in the middle of the jaw, and it wouldn't numb the tongue. So if we were working on anterior teeth, which is the teeth in the front, that would be an ideal injection as opposed to numbing half the tongue, half the jaw, and half of the lip, especially if they have to go back to work. This is part of the oral anatomy that we'll be learning. So if you put your tongue up to the roof of your mouth, you can feel your hard and soft palate. Right after the soft palate, you'll see your uvula if you look in the mirror. Of course, if you say, ah, you can see your tonsils. A lot of times the doctor will do that and have you stick your tongue out and do an oral cancer check. Your uvula also helps with gag reflex. So your mouth can tell you whether or not something is going to choke you. We want to keep our suction away from the soft palate and the uvula. You don't ever want your suction to go this far back in the mouth because you could severely injure a patient. The lingual frenum is the soft attachment and little tendon that attaches your tongue to the floor of your mouth. The labial frenum There's two actually, and it points to one on the upper and one on the lower. So there's a maxillary and a mandibular, which will show you exactly where the midline is in the body between the two front teeth. Your buccal vestibule is the area and space between your teeth and your cheek. Gingiva is a new word for you guys, so I don't want you to refer to it as your gums anymore. It is now gingiva. So we have two different types. We have attached gingiva. So this is the 4 to 6 millimeter band of tissue directly surrounding the teeth. This is tough skin comparable to external skin on the body. So this would be your gingiva that's attached right here close to your teeth. Your unattached gingiva, this is the thin, delicate skin lining your cheeks and coming to within 4 to 5 millimeters of the teeth. This is also called mucosa, as it sweats mucus, which is saliva, to keep the mouth moist. The next picture shows the demarcation between attached and unattached gingiva. So the biggest deal here is that a lot of times if you ever have really bad gingival margins and you've had really bad recession, we can graft part of your unattached gingiva, whether it be the soft palate or maybe a piece up here on your cheek, and put it down here on your lowers or wherever it needs to be in the mouth, which is something a periodontist or an oral surgeon would usually do. All right, let's talk about salivary glands. This is so important in the mouth because it lubricates, cleanses, it's going to aid in digestion and remineralize your teeth. So remember we talked a little bit about diet. It's really important that we have a healthy diet because our saliva is dependent on our diet. Our teeth are only going to be remineralized if our saliva has the ability to do so. So it's important that we drink water throughout the day. We're not, drenching our teeth in sugary drinks or foods all day long, that we're brushing and flossing like we need to. So that way we can take care of our teeth and know that it is being remineralized. Minor glands are scattered in the tissue of the buccal labial and lingual mucosa, the soft palate, hard palate, and the floor of the mouth. Here's a better picture of what I'm talking about. So you have 3 parotid, submandibular, and 1 sublingual. The parotid gland is really big. So it is the largest and is located below and in front of the ear. So you can see a picture of it right here. Saliva passes through the gland and into the mouth through the parotid duct, otherwise known as Stenson's duct. This is the one that can get clogged by calcium buildup. If you have ever had radiation treatment, or maybe your diet is causing some sort of calcium buildup, and it can be very painful because your cheek can swell up because of it, because your saliva is not able to pass through the duct like it's supposed to. The dentist is able to help with that if that ever happens. The submandibular is going to be behind the sublingual gland. So your submandibular is just below it, and then you have your sublingual. The sublingual is going to be underneath the tongue. So these two work together to also create saliva in the mouth and help keep it salivated. And we don't want a dry environment in the mouth because it's not good for our teeth. Anytime our mouth is dry, it causes bacteria and food to stick to our teeth, which is the last thing we want because that will create a carie, which is otherwise known as cavities. All right, let's talk a little more in detail about the arches of the mouth. So we have our maxillary, or otherwise known as our maxilla, which is the upper part of the skull, not capable of movement. We also have our mandibular, which is the lower, and it is movable through the action of the temporal mandibular joint. Occlusion. Occlusion means both arches are in contact. It is another word that we use for bite, to occlude. A quadrant in dentistry, sometimes you'll hear us say, oh, we're going to do quadrant dentistry. So we're going to numb this quadrant of the mouth. And you know, do these fillings or this crown and fillings over here on the maxillary right. So a division of the maxillary and mandibular arches into halves, resulting in 4 sections. There is a lot more detail and pictures in your textbook for your homework. So if you want to go in and check that out, that would be a good idea. So if we're going to be dividing up into quadrants, we have a maxillary right, a maxillary left, which is divided by your midline. And then we also have a mandibular right and a mandibular left. Sometimes the doctors will like to discuss and chart dentistry in sextants, which is a division of arches into 6. So we could do a maxillary right posterior sextant, a maxillary anterior sextant, maxillary left posterior sextant, or mandibular right posterior sextant. And it goes on like that, breaking it up into the division of the arches into 6. Teeth identification by name. It is very important that you know this as a dental assistant. So we have on here your primary and your permanent teeth. Your primary teeth are all 20, right? You have 20 teeth as a baby. So you'll have upper and lower central incisors, lateral incisors, canines, first molar, and second molar. Notice as a baby, for your primary teeth, you do not have premolars. There are no premolars in the primary dentition. In your permanent dentition, you have your central incisors, your lateral, your canine, your first premolar, otherwise known as your first bicuspid. But to be honest with you, we don't really use the word bicuspid anymore in dentistry. It's kind of outdated and it's not something you'll hear very often. So you have your first premolar, your second premolar, and this is in order of eruption. That's why it's called a first premolar and a second premolar. And then your first molar you get when you're about 6 years old, your second molar when you're about 12, and your third molar somewhere around 16 to 21, or maybe never. You might never get your wisdom teeth. Posterior versus anterior. So you've heard me use these terms quite a bit since the beginning of this lecture. Your posterior teeth are the teeth that are going towards the back of the mouth, like your premolars and molars. We would consider those to be posterior teeth. Your premolars are a cross between your canine and molar, otherwise known as your bicuspid. They have 2 to 3 cusps, and they have 1 to 2 roots and a broad surface for chewing. So your premolars are a little bit smaller than the regular molars are, and they're right behind the canines. Your molars are the largest teeth in the mouth and have 4 to 5 cusps. You have maxillary and mandibular molars that differ from each in size and shape and cusp. When you become an expanded duties dental assistant, you'll learn about the different pits and fossas and cusps of each molar, because you will be expected to recreate that anatomy in the tooth once you're placing a permanent filling. Your anterior teeth are toward the front of your mouth. So these are your incisors and canines. So basically from canine to canine are your anterior teeth. It's visible when you smile. Your incisors are single-rooted teeth with relatively a sharp, thin edge, which is what we call our incisal edge, which you're going to learn in a minute. And it's designed to cut food. So you have central incisors, which are your 2 front teeth, and you have lateral incisors. And then your last one on anterior are your canines, otherwise known as your cuspids. This is the longest rooted tooth in the oral cavity, and it is designed to cut and tear food with force. Your canines help shape your face and your bone structure, so they're very important teeth. When we start to review radiology, you'll be able to find those canines the fastest because of how long those roots are in the mouth. Oral anatomy tooth surfaces. Okay, let's take a look at the maxillary. This is your upper jaw, and what you see here is all the different tooth surfaces that we use to identify when we're talking about fillings or anything in the mouth that needs to be addressed, or maybe we're charting some previous treatment. The first one we're going to start with is the buccal surface. The buccal surface is the area of your teeth that touches your cheeks. So this is only considered on your posterior teeth, which is your molars and your premolars. So that outside surface that people always want to bleach way in the back, though don't really need to unless you smile that big, is your buccal surface. From canine to canine is what we consider your facial surface, what you see on your front teeth, where you brush on the front teeth in circles, where you bleach usually, and where you smile. This picture shows labial and facial all the way down to the posterior tooth. Some doctors will call it that, but for insurance purposes, which basically runs our life in dentistry, the buccal surface is only posterior and the facial is only canine to canine. If the doctor says, we need a facial on tooth number 3, you're not going to correct them and say, you mean buccal, right? You still understand what they're saying. You're saying the surface towards the cheek side. On the maxillary, we also have on the inside what we call lingual, which is this area that your tongue touches. Now, this is not divided by posterior and anterior. It is all considered lingual on the upper and the lower. The only difference is if we're doing an oral surgery check, or sorry, I apologize, if we're doing an oral cancer check, the doctor will sometimes refer to that tissue as palatal because that is the palate of the mouth on the maxillary. So those two are interchangeable for lingual and palatal on the maxillary. If you're charting, however, it will only accept lingual. Insurance will not recognize palatal as a surface on a tooth because we are referring to the palate of the soft tissue. The other thing you see on the maxillary teeth are little black O's drawn on the biting and chewing surface of the posterior teeth. That stands for occlusal. So that is our occlusal surface of the teeth. These little O's here. So this is our occlusal surface where all of our Oreos and Cheetos and all those bad things get stuck. That's your occlusal surface. The other area you see that's highlighted in green on the edges is your incisal edge. This is the area that we use to cut into food with, like sandwiches, hamburgers, anything like that is what we use to bite on our anterior teeth is called an incisal edge. The other surface that I want you to learn is the surface in between the teeth where we floss. So this lower diagram down here is showing you if your teeth were divided and you could see in between them. You see the little F is for facial because it's facing us. The O is again occlusal where it's red on the top of the tooth. The lingual is on the opposite side where the tongue touches and it's pointing to it. And then in between the teeth you see a D and an M. One surface going posterior toward the back of the mouth is going to be considered distal. The other surface that touches the distal and meets up with it is considered mesial. This will make a lot more sense once you guys go through your little charting exercise. We also are going to give you a model to take home today so that way you can label all of these surfaces and get to know them and start studying that for your exam. So here's all of the tooth surfaces that we talked about. So we have facial, which is the surface closest to the face, labial, which is the facial surface closest to the lips, but again, interchangeable. Labial is not a term that we use often when charting. Buccal is a facial surface closest to the inner cheek. The lingual is the surface of both maxillary and mandible closest to the tongue. Palatal is a lingual surface of maxillary dentition. The word masticatory is a chewing surface. This is more of an explanation. This is not what we would consider a surface of the tooth that needs to be restored. It can be used in charting when we are describing oral cancer, however. Incisal is the cutting edge of the anterior teeth. The occlusal surface is the chewing surface for posterior teeth. And then, of course, we have in between our teeth where we floss, we have a mesial, which is the surface going towards the midline, and distal, which is the surface distant from the midline. Proximal is more of an explanation that these surfaces are adjacent to each other. And interproximal is the area between the adjacent surface. So they could have, let's see, we floss interproximally in between our teeth. So that would be a good definition for the word interproximal. Now that you've learned the teeth names, we're going to move on by teeth identification by number. So for primary teeth on the bottom here, you know we have 20. However, they have lettered them. They are not numbers. The funny thing is a lot of times your doctor will say number D, and you're like, okay. So just so you know, you've been warned. Okay, so the way you're going to do this is you will start on the right side of the patient. Do not start counting in your mouth. Don't get in that bad habit because you probably, first of all, don't have all 32 teeth. And if you're trying to do a primary, you don't have your primary teeth either. But who knows? Some adults do keep some of their baby teeth. So you could have one or two. However, you don't have a full primary dentition. So don't get in that bad habit of counting in your mouth because you'll be opposite. So just as you're looking at the screen, you see right is on your left side and left is on your right side. And this is how we want you to memorize it because you will always be facing your patient when you're working on them. So you need to remember their right is your left. So you will start on the patient's upper right, and it will start A through J and K through T for your primary baby teeth. A good way to remember it is AJ and Katie. Of course, Katie is spelled backwards, if you guys noticed that. The upper is your permanent teeth. So again, you're going to start on the patient's right side. You're going to start from number 1 all the way through 16. Then it's going to drop down and go 17 through 32. You will be doing an exercise numbering the teeth and putting the letters down for the primary teeth as well. So that will help. Another thing that will be good is on the model that we're taking home, when you're putting your surfaces on there, you're also going to be identifying those teeth by number. One of the things this slide is telling you is to use landmark teeth. So if you can memorize your first molar, which you see here in blue, so you have 3, 14, 19, and 30. If you can memorize those and identify them on an x-ray, you know what quadrant of the mouth you're in, so then you can identify the teeth a lot easier. So if you automatically see number 30, you know you're in the lower right quadrant. Or if you can identify your canines for the anterior, which is highlighted in red, you'll see 6, 11, 22, and 27. And you'll know that, okay, we're on the upper left or we're on the lower right, wherever the case may be. And it'll be a lot easier for you to identify those teeth and number them. So this is just reminding you what you can use as landmarks for your teeth. Again, so your maxillary is going to go 1 through 16 and 17 through 32 on the mandibular. You're always going to begin on the patient's right side, on the upper right. So try not to get in those bad habits of looking in your mouth. All right, let's talk about charting. There is an exercise you will be doing in class for charting on paper charts. We will always be using red for treatment, green for existing other, blue for existing that's completed, and the black on here is usually going to be a condition. All right. So our crowns that you see on here, like your PFM is your porcelain fused to metal. We will review each crown and what it looks like when it is charted. Your Emax and zirconia are going to look a little different, and of course your full gold crown. We will also review fillings and amalgam with composite. So all of those different types of chart notes are in your book, and you can look them up on, let's see, page 31 and 32. There's a charting exercise in your workbook, and I would definitely suggest doing that. It is not part of your homework on your schedule, but it will help you with charting. Paper charting is important for you guys to really understand the basics of charting. That's why we have this in here, and we want you to do the labeling exercise in the workbook. So again, page 31 and 32 shows you the tooth anatomy and charting. Also, if you want to do a numbering exercise, you can use the chart on page 47 to go in and number the teeth and practice numbering. Remember, start on the upper right of the patient. So if you need a label, here's the right, here's the left to help you out so you don't get confused, that's okay. Go ahead and do it. On your student portal, you will see on the week 1 lecture info, there is a link to Dentrix, which will show you electronic charting, electronic scheduling, which is really good. The toughest part about this is that we don't know what kind of software you might use once you graduate in the office. Dentrix is definitely common. It is very common, so we're lucky enough to have those videos to show you guys. Also, there is a DVD in the back of your workbook that you're more than welcome to utilize and practice charting on as well. So I would do that if I were you. The classifications of caries we will go into in more detail in week 5. However, it is a good idea to go ahead and get started now. In chapter 13, when you read through dental caries, they are going to discuss how they form, what causes them, what type of bacteria in the mouth causes them, but they do not talk about classifications until chapter 43, which is the review of dental classifications. It's general dentistry, and it talks about all that good stuff. So you have class 1 through 6 here. The most common one you are going to hear referred to is class 5, which is the second one to the bottom. And it's right along the gum line that you see the caries, which is the decay of the tooth, otherwise known as a cavity. In dentistry, we call those caries. And a lot of times it's because people aren't, they're just, going through really quick and brushing as fast as they can, and they're not making those little circles and coming in contact with the gingiva like they should be. Or maybe they have dry mouth syndrome. Remember I said a dry environment in the mouth is never good because it causes that bacteria and plaque to form and stick to the tooth. So if you have those issues and you're not brushing 3 times a day, then you will see more class 5 classification of caries. So for an example, your doctor will be giving an exam and you'll be taking your notes down, right? And you're writing everything down to put in the chart. They aren't most commonly going to say, okay, we have an occlusal on number 1, class 1, right? That's just too much. That's too much of a mouthful. Or they're not going to say we have a class 3 on 6 NFL. They're going to tell you the abbreviation for the surface that you learned. So if we had a class 3, which you can see is on the mesial, the mesial and distal surface of the tooth, then they're going to tell you number 8 has an MLD, and it could be mesial, lingual, distal. They're not going to say number 8 has a class 3 MLD because that's pretty much the same thing. The most important part is we know exactly what surface, because it could be, number 8 has a mesial facial lingual or a mesial facial distal, or let's say it's a lingual facial distal facial, but they don't touch, right? So it's important for you to know those surfaces and the tooth numbers, because we are going to be using that every single day in our job. Not only that, but you're going to need it to pass your exam, right? But more importantly, to get a job and to be able to do this correctly every day. So class 5 is the one that you will hear them refer to. They will say number 30 has a class 5 on the buccal, or number 30 has a class 5 on the lingual. And we know that that cavity is right along the gum line. The other classifications they don't refer to as often, but it is good for you to know them. Occlusion. Let's talk about occlusion and the relationships of the jaw. When we do talk about ortho, we'll go into a little bit more detail in why it's so important for them to correct occlusion. It usually will keep you out of the dental chair because you'll be able to keep your teeth clean, easier to clean things when they're lined up and straight, and you don't have to go in there and work too hard. So your occlusion is the relationship between the maxillary and mandible. Habits can affect occlusion, like thumb sucking, bottles, sippy cups for too long. Any bad habits like that when baby's teeth are forming can affect the occlusion of the mouth. Centric occlusion is ideal. So this is when the jaws are closed in a stable contact. Condyles, remember your condyles, are seated in your TMJ. So they are in the most posterior unstrained position because we don't want to put any strain on those ligaments and that the temporal mandibular joint. We don't want any popping or anything. And this is what we would consider a standard, is centric occlusion. And that's the biggest reason why we like ortho and we want ortho, is because we want the jaw to not have strain on it, and we don't want the teeth to wear funny, if there's strain on the jaw. So centric occlusion is ideal. A malocclusion is abnormal relationships of the maxillary and mandibular dentition. So anytime a patient has a malocclusion, this is when we would refer them to an orthodontist. This is what would be considered a malocclusion, is a class 1 a class 2 or class 3. So class 1, what you see here is what we call neutral occlusion. So neutral occlusion is the ideal relationship of the first molar, which is, defines the classification. So it tells you the mesial buccal cusp of the permanent maxillary first molar meets the mandibular permanent first molar's mesial buccal groove, which is exactly where these arrows are pointing. So if you look at the right side of your model that your instructor so nicely put together for you, you will see that those models are in neutral occlusion. And the mesial buccal cusp is in line with the mesial buccal groove, that little groove in the bottom tooth. You can see it right there. Class 2 is a malocclusion, so this is not ideal. This is called distal occlusion. So class 2 is distal occlusion. It's when the mandibular arch is in a distal relationship to the maxillary arch, and it gives the appearance of maxillary teeth protruding over the mandibular teeth. So this could be them like a buck tooth. We don't ever want to refer to it as that because it can be very offensive to people. So please don't ever use that. But this is distal occlusion when the mandibular arch is in a distal relationship to the maxillary. The other malocclusion is a class 3, which is called mesial occlusion. The mandible is in an abnormal mesial relationship to the maxillary, and it's the appearance of protrusion of the mandible. Dental caries. So we talked a little bit about dental caries today, and you will read a lot more about it in your textbook. Dental caries are caused by tooth decay and a bacterial infection in the mouth. The bacteria is called mutans, and they're called streptococci lactobacilli. So, streptococci lactobacilli. So we call them strep mutans for short, right? That's a lot easier to say. That kind of bacteria gets into your mouth through transmission of sharing drinks, kissing, and so here's the sad part, right? You're little, your parents kiss you, boom, you got it. I mean, that's pretty much it. It doesn't just show up automatically. But everybody has this type of bacteria in their mouth. Children, their common chronic is transmission through dental plaque, colorless. It's soft, sticky coating that sticks to the teeth after bacteria is in the mouth. And if it's not brushed off, it will start to cause demineralization, and it will end up forming calculus. Now, this is a pretty severe picture we have up here of caries, dental caries. This has staining on it. It has recession. The gums are very irritated. It looks like they have periodontal disease or possibly some very serious gingivitis going on. And they just need a really good cleaning, possibly some restorative treatment and a little bleaching. And, we can probably save and restore the majority of these teeth. treatment is always going to be some sort of restorative treatment. We don't want to extract teeth. We want to save teeth, because space in the mouth is never good. It causes super eruption and movement, and we don't like that, because then we will end up losing more teeth than one. We could end up with what's called recurrent caries at the bottom of this page here. If someone has had treatment, and let's say they have a crown or some sort of filling material, and they don't take care of it, that treatment will fail and gain another cavity if it's not taken care of. So let's talk a little bit about how we can take care of our teeth, right? We want to prevent caries. We don't want to be in the dental chair. We don't want to get a shot in our mouths. It's not fun. So let's talk a little bit about that. So what you see here, the number one thing it starts with is diet, which is really, you know, it's tough for a lot of people, right? We're on the go, want to grab whatever is quick and easy and eat and go to the next thing that we got going on. So diet is a big deal. It's important for us to eat a healthy and balanced diet, so that way our teeth get the vitamins that they need to and the nutrients. Brushing and flossing, number two, huge, huge, huge issue, right? If we don't brush and floss properly, we can't clean our teeth. So if we don't clean our teeth, bacteria is going to form, and things are going to start to demineralize, and cavities will eventually start to form and cause problems in the mouth. So brushing and flossing is so important. Your toothbrush cannot fit in between your teeth. So the only way your teeth ever get cleaned interproximally is by flossing, even when you go in to see the dentist, right? Even when you go in to see your hygienist, the only way they clean between those teeth is to floss. So it's very important that we do a really good job at our home care and make sure we're taking care of ourselves before we come in to see the hygienist and get the calculus scraped off if there is any. Fluoride is very important. So let's say our diet isn't all that, right? None of us are perfect. I can't honestly say I eat a vegetable every day. But let's just say, you know, it's something that we can't really control, and we take vitamins, but maybe we have some sort of medical issue going on and we have to take prescription for it, and that causes problems for our teeth. Well, they have this amazing thing called fluoride that will remineralize your teeth. So throughout the day, let's say you were sucking down Red Bull and Dr. Pepper and whatever else is, you know, acid and sugar and all those acidic things that are bad for your teeth. At the end of the day, if you're brushing and flossing and using that fluoride, it really shouldn't be a problem. Because how many of you have gone into the dental office and been like, my dentist gives me chocolate chip cookies? That's crazy. Or they have sugar and they have candy that they hand out. Well, it's okay, because they actually do have a balanced diet. They are drinking water throughout the day. And the number one thing that they do is brush and floss afterwards, right? And we always brush with a fluoride toothpaste, and then we do a fluoride rinse to make sure that we're coming behind and making sure and getting that remineralization that we need. Oral hygiene is really big. You need to see your hygienist at least every 6 months, which is twice a year, unless they tell you otherwise. Saliva will be determined, of course, by our diet, how much water we take in and what we're eating. Mouth rinses are, you know, we're going right back to that fluoride. Whether it's fluoride treatment with oral hygiene or we're doing it at home, it is a really big deal, and it's something that we should be taking care of. Sealants are a great preventative for caries. Sealants will close off all those deep pits and fissures that we have in our teeth, especially for little kids. A lot of them don't have time while they're in school to just stop and brush and floss, you know. So sealants will stop those foods, those sticky foods, from getting stuck in between their teeth and sitting in the occlusal surface for the next hour to 2 hours, you know, until it finally washes away. So try to keep this in mind. If you aren't brushing and flossing on a normal basis, I hope that you start doing so, especially after reading the majority of the information in your textbook on week 1 and 2 and how cavities form and what exactly is going on in the patient's mouth. If you have any questions, you're more than welcome to send us an email or ask at the next class. I hope you have enjoyed your week 1 lecture, and we will meet again.